2019 and published in 2022. So they want to measure what is the effect of antimicrobial resistance on our health and our morbidity and mortality rates. So they made an analysis reviewing 33 pathogens and 98 pathogens with a drug combination resistance. They reviewed 244 countries and territories in 2019. That include around 471 million individual record or isolates. Can you imagine what was the report conclusion or the result at that time? What they found that 1,027,000 deaths were directly attributed to drug-resistant infection globally, and 4.9 million, which is almost 5 million, deaths were linked with bacterial antimicrobial resistance. So that's why they make an act. Actually, this study, they even make a study. If we continue doing this thing, if we continue having this antimicrobial resistance, what would be the expected death by 2050? So when they did their measurements, they found that by 2050, in dark color, the expectation that the number of those who will die secondary to antimicrobial resistance will be equal to those who die with cancer. Can you imagine that? So the number will be duplicated by I don't know how many times. But you have an antimicrobial resistance organism and you don't have enough antibiotic or an antibiotic to treat him and to manage him and save his life. So that's why we are studying the gene. What are the gene? How this patient, whenever he is hospitalized, he will get this antimicrobial resistance organism. Actually, we are the gene. We are the one who link the infection to the patient, or we are causing the infection directly or indirectly. So using hospital facilities like bathroom, locking the door, opening the door, touching the surfaces. And this is the role of housekeeper, the role of environmental cleaner. And this is what we are going to review today. The role of each one to prevent this infection and break the chain of infection. Medical equipment, implants, devices. So inserting lines, inserting catheter, inserting prosthetic joints, any implant in the body. If you don't have a good practice of infection prevention following the standards, again, you are indirectly or directly infecting the patient. So we are the gene. It is our role to prevent this as a housekeeper, as a doctor, as a nurse, as a any one of the staff, from the smaller, or I would say the junior staff to the most senior staff. It is our role to prevent this chain and break it. So breaking chain will save their lives, as you see the report that's published in Lancet. And if someone asking, is there any impact to do, is that will prevent in future the deaths, the rate of death and the rate of infection? Actually, yes, if you review the literature, it showed that I just posted two studies. The impact, the first one is the impact of multimodal strategies to reduce MDR and surgical intensive care units by only knowledge, practices, and giving a feedback. So they recruit 62 new healthcare practitioners from 2017 to 2019, and they collect the data reliably. So they did enhanced training, education, poster inside the unit to remind everyone about the practice, the correct practice. They made a YouTube channel with educational material, and they announced champions. So those who get or have a good practice, they give them a feedback, a good feedback, or a certificate of appreciation. And this is the result of this study. What they have seen by then, that the median knowledge score increased from 16 to 17 with good p-value or significant p-value. The overall correct MDR prevention practices increased. The correct practices increased from 76% to 94% with significant p-value. And by the end, the MDR transmission rate decreased from 25% to 0%. This is only by very simple and very applicable. And this is one of them, is the education, reminding everyone what are the correct practices. So this finding indicate that multimodal strategies, very simple strategies actually, could enhance knowledge and practices for preventing MDRO and prevent the transmission of the bacterial by healthcare workers. This is another also study done in Lebanon. They want to see the impact of strict hand hygiene, wide hand hygiene, and reminding and following the hand hygiene percentage inside the unit, and how this will affect by the end the rate of Staph aureus and C. diff infection inside the hospital per 1,000 inpatient day. So again, when they did a report, continuous surveillance, continuous monitoring of hand hygiene, they increased the compliance from 41% to 87%. Again, it's significant value. And by the next year, actually the following year, it's increased to 91. It will decrease the MDRO rate inside the hospital. So first is the activation of antimicrobial stewardship, and I believe that we are doing great on this. Actually, it's established already in our hospital, and there will be an activity by the ID physician at the pharmacy in our hospital regarding this program. And I'm advising everyone to attend because it's amazing. The work that they are doing is amazing, and we have seen the impact on the MDRO rate and also on the antimicrobial sensitivity. Enhancing infection control measure. This is the most, one of the, have shown that if you have good infection control, we will develop studies studying the impact of the effectiveness of infection control practices. This will give us a good picture and a clear picture how come it's effective. So as we see, saving a life means to break a gene and by the end prevent infection, and it is a role of everyone. It's a role of nurses, it's a role of our physicians, and all of this is by only simple and very cheap, I would not say cheap, but very simple, that is available materials to prevent the infection. So this will be our lectures today. It's mainly regarding the
Talk about the basic of infection control. First of all, what's infection prevention and control? Infection prevention and control is a scientific approach and a practical solution designed to prevent this. It's provided to all healthcare workers, and it's valid for 2 years. Before it was for 1 year, and now the big cell, it's valid for 2 years. So the big cell components, it include hand hygiene, PPE, transmission-based precaution, needle stick injury, spill case, respiratory testing, and PFAI. Today, inshallah, we will cover the basic components. First of all, we will start with one question. What are the most common vessels to transmit healthcare-associated pathogen? Any answer?
Hand.
Hand. So hand hygiene is the single most effective measure to reduce healthcare-associated infection. What's hand hygiene? Any method that remove or destroy microorganisms on hands. So for hand hygiene, we have hand wash and hand rub and surgical hand wash. For hand washing, what's the duration for hand washing? 40 to 60.
Seconds.
So the hand wash, it's clean the hand with soap and water. I'm sure we all know or seen this the sign. So what's the step of hand washing?
Wet hands.
First, wet hand with water. Apply enough amount of soap. Rub hands back to back. Then using APHR with 60 to 95% alcohol. It's before clean aseptic procedure. And we have 3 after. after body fluid exposure, taking vital signs, give a catheter insertion. After body fluid exposure, after patient contact, after taking vital signs, or after doing the physical examination for the patient. After contact with patients surrounding, after changing linen, expectation, all of us must comply with the hand hygiene with the 5 moments. Now we will go to transmission-based precaution. So at the hospital or at MOH overall, we have 2 types of precaution: standard precaution and transmission-based precaution. Standard precautions, it's applied to all patients all time. So this practice are designed to both protect patients and prevent healthcare workers from spreading infections among patients. The standard precaution covers performing hand hygiene, use PPE, respiratory hygiene, and cough etiquette, use aseptic technique, use and dispose sharps safely, cleaning and process reusable patient equipment, performing routine environmental cleaning, handle and store waste safely, handle and store linen safely. So this applies for all patients all the time. The transmission-based precaution, it's applied in addition to standard precaution. So it's the second tier of basic infection control to be used in addition to standard precaution for patients who may be infected or colonized with certain infectious agents for which additional precautions are needed to prevent infection transmission. We have 3 types of precaution: airborne, droplet, and contact precaution. So the contact precaution was to reduce the risk of a transmission of microorganisms transmitted by contact, and we will go to each one of this precaution in details. First one, we will start with the contact precaution. I'm sure you are all familiar with this precaution. First of all, contact. What's the indication for contact precaution?
Reduce the risk of transmission.
First, it's to reduce the risk of transmission of microorganisms transmitted by contact with patients or the patient's environment, like MDRO, C. difficile, MRSA, patient placement. So in case of contact precaution, we prefer a single room to put the contact isolation sign on the door. But if the single room not available, we can cohort patients the same disease or the same organism on one room. What's the PPE for contact precaution? We should limit the department of the status the following before entering into the patient room. Practice hand hygiene and wear isolation gown and gloves before entering into the patient room. Before leaving the room, also remove gown and gloves and perform hand hygiene. Then we have the droplet precaution. So the droplet precaution, it's used to reduce the risk of transmission of microorganisms transmitted by at least 6 feet. BBE for droplet precaution, the healthcare worker should wear a surgical mask on room entry, handle items contaminated with respiratory secretion with the gloves, and change BBE between patients and perform hand hygiene. Patient transport, we will try to limit patient transport outside the room to medically necessary purposes only. If the patient must leave the room, instruct the patient to wear a surgical mask and follow respiratory hygiene and scalp etiquette. Once the patient is masked, the patient transporter doesn't need to wear a surgical mask. And of course, notify the receiving department on the isolation precaution status. So, the healthcare worker should be instructed to do the following. Before entering into the patient room, practice hand hygiene and wear surgical mask. And before leaving the room, remove surgical mask and perform hand hygiene also. At the end, we have the airborne precaution. The airborne precaution used to prevent and reduce transmission of microorganisms that are airborne in small droplet nuclei, less than 5 in size. So they can be inhaled by or deposited on a host in the same room or further away. Include such disease like what? Which organism or disease based on negative pressure room, isolation room, and there should be at least 6 to 12 air changes per hour, and air should be directly exhausted to outside the hospital. What BBE should be wear in case of airborne precaution?
N95.
N95, fit tested N95. Also, we will limit the transport of patients to essential medical purposes only. If the transport out of the room is necessary, we will instruct the patient to wear a surgical mask and instruct him to observe respiratory hygiene and scalp etiquette. A transporter don't need to wear respiratory protection during the transport if the patient's mask and all skin regions are covered. So, all healthcare workers should be instructed to do the following before entering the room: to practice hand hygiene and wear a N95 mask before entering the patient room, and before leaving from the patient room, give the purpose of precaution to the patient